Welcome all. Thank you for joining the Johns Hopkins Government and Community Affairs GCA Showcase Series conversation. The Showcase Series highlights different programs across the Johns Hopkins and the impact programs and the programs that impact the state. My name is Delegate Jocelyn Peña-Melnick. I represent the 21st District, which is Anne Arundel and Prince George's County. I will moderate today's discussion. Today, we will learn about the Johns Hopkins Center for Equity, their research initiatives, and their influence on public policy in practice. Before we get into the discussion, I want to go over some logistics. This webinar will be recorded and will be posted to the Johns Hopkins at-home websites with captions included. Additionally, the questions and answers function has been enabled during this webinar. Please feel free to type questions there. We will do our best to respond to as many questions as we can in the time that is available. With that, I'll ask Dr. Cooper and Dr. Cruz to tell us more about the Center for Health Equity. Good afternoon, ladies.
Good afternoon, Delegate Peña-Melnick. It's our pleasure to be with you today in conversation about health equity in Maryland. So I am Dr. Lisa Cooper, and I'm joined by my colleague, Dr. Deidre Cruz. I'm the director of the Johns Hopkins Center for Health Equity, and Dr. Cruz is the deputy director. We're both professors in the schools of medicine and public health, and we have dedicated our careers to addressing health equity through research, through clinical practice, and also through education. So first, we're going to just start out talking about health disparities, which, as many of us know, are preventable differences in the burden of disease, injury, violence, or opportunities to achieve optimal health that are experienced by groups that have been economically or socially marginalized, oppressed, or minoritized. Now, the data that I'm showing here is for heart disease. And the reason I've chosen heart disease to share with you, although we know health disparities exist for multiple conditions, is that cardiovascular diseases, which are diseases of the heart and blood vessels, are the leading causes of death in the United States and the greatest contributor to racial disparities in life expectancy. So this graph really shows that although the death rates from heart disease have declined over time, that they remain elevated, particularly for African Americans. We do know that uncontrolled hypertension is actually the primary contributor to disparities in cardiovascular disease deaths between Black and white people, as well as between persons with lower and higher levels of income. So it's with that backdrop that my colleagues and I were fortunate to compete successfully for a large program project grant in 2010 from the NIH, and were able to establish the Johns Hopkins Center for Health Equity. Our center focuses on addressing cardiovascular health disparities primarily, but also disparities in multiple other chronic conditions. Our mission is to promote equity in health for populations experiencing health disparities through advancing scientific knowledge, educating and training leaders, and partnering with communities. The center includes 44 faculty from diverse disciplines in the schools of medicine, public health, and nursing at Johns Hopkins, more than 20 staff members, over 100 trainees, and more than 60 community and health system partners. And in 2020, we celebrated 10 years of promoting health equity for vulnerable populations. So we're now at our 12th year. So this slide shows the center leadership. You can see yours truly, the director, and then Dr. Cruz, who is the deputy director. We're joined by a very capable group of colleagues and staff members, Ms. Nancy Molello, who is our program director, Dr. Chidima Ibe, who directs stakeholder engagement efforts, Reverend Deborah Hickman, president and CEO of Sisters Together in Reaching Incorporated, who is the co-chair of our community advisory board, Ms. Kit Carson, who heads up our statistical and research methods programs, and then Katie Dietz, who is our program administrator. As I mentioned to you before, we have a three-pronged approach that includes community engagement, research, and training. And so in terms of our community engagement, we've established an active community advisory board that includes individual patients and family members, as well as community advocates, organizational leaders, and people from health systems, as well as policymakers. We use our community engagement to raise public awareness about health inequities and to provide expertise to support practice and policy changes at the level of institutions, local and state governments, as well as the federal government. In terms of our research to advance scientific knowledge, we advance knowledge to identify solutions to disparities in Maryland and beyond. So our research has identified effective programs for reducing disparities in outcomes of chronic conditions such as high blood pressure, kidney disease, and depression. Our programs enhance patient self-management, behaviors, and the health professionals who care for them's abilities to address complex social and medical needs. We've also tested programs that increase consumption of healthy foods among people living in health deserts, and those using health information technology to enhance their access to care. And our newest project called the Mid-Atlantic Center for Cardiometabolic Health Equity is going to test several new programs that are informed by the best available current evidence to improve cardiometabolic health outcomes in Maryland. And Dr. Cruz will be telling you more about that. In terms of education, we've trained more than 150 people in Maryland, many of whom are from underrepresented groups in science and healthcare. And we've trained over 6,000 researchers and practitioners across the United States and globally through our courses, our Johns Hopkins courses, as well as our massive open online courses. We have a very robust seminar series called our Health Equity Jam Sessions, where we have monthly presentations on health equity research happening at Johns Hopkins, as well as other institutions in Maryland and around the United States. Additionally, we offer individualized mentoring to individuals who want to improve their research or their practice skills related to advancing health equity. As I mentioned to you before, we do all of this work in very strong collaboration with the community. And these are some photos taken at some of our community advisory board meetings. We have a very robust partnership, as I mentioned, of over 60 organizations and individuals. As part of this process, we equitably involve all partners in all aspects of our work. And our community advisory board members help to assure that our work is responsive to the needs and preferences of our communities. They represent national and local organizations, as well as health systems and professional societies and local community-based organizations. They all share their expertise, they share responsibilities for our outputs, they participate in all phases of our research and training efforts. And then as well, our faculty members participate in events that are being sponsored by our community members. We attend community forums where we educate the public about health and healthcare research and attempt to connect individuals with health-related resources. So we have a paper that describes the evolution of our partnership that I've cited at the bottom. And as you can see, that people are very engaged and interactive, and we've developed strong relationships over time that have really led to increased trust. This is just a sampling of who some of our partners are from health systems, including federally qualified community health centers, people from the bio and pharma industry, and then also some of our representatives of different organizations on a community level. So back in 2010, when we first established the center, we conducted 3 studies that tested whether interventions from clinical trials could improve hypertension disparities or reduce hypertension disparities in real-world clinical practices and communities. And we'll tell you more about the impact of these projects, but basically one of them was called Project Red Chip, was focused more on health system quality improvement. The other one was called 5+ Nuts and Beans, which looked at whether dietary advice and assistance with grocery ordering by a health coach, as well as food delivery, improved the consumption of healthy foods. as a strategy to improve blood pressure control among people who were already getting treatment. And then the ACT study compared the effectiveness of 3 different programs involving community health workers to assist individuals in managing their hypertension. We successfully completed those 3 studies, which were very informative, and we'll tell you more about the impact of that when we have our conversation. But suffice it to say that work led us to another project called the Rich Life Project, which we have just recently completed, to actually enhance what we learned from our previous work. This trial included 30 practices in Maryland and Pennsylvania, where we enrolled 1,820 adults, about 60 patients per practice. These were people who had uncontrolled hypertension plus at least 1 additional condition. And we basically assigned the practices to be either in a group that we called Standard of Care Plus, which focused on providing training and feedback about clinical performance on hypertension to the clinic staff and system leaders, and compared that to a program that also included a nurse care manager, community health worker, and a specialist team. And we've examined our outcomes now at 12 and 24 months. So we've been looking to see which program actually worked better for blood pressure control and for patient activation. So stay tuned. I'll tell you more about what the impact of that has been, but it was very, very well received. And we achieved all of our recruitment goals as well as our follow-up goals because we had so much engagement from our partners. In terms of our training programs, we created a model training program for health professionals and practitioners. We lead 2 courses in the Bloomberg School of Public Health, and we also provide leadership for several courses in the School of Medicine, as well as for residents. As I mentioned to you before, we have our Health Equity Jam session, which is our monthly seminar series. We've actually had over 7,000 people in attendance at those sessions between 2016 and 2021. And then our 2 massive open online courses are now available, and we've trained over 6,000 people through those courses. Now, the people who come to train with us can range all the way from high school students to college students and undergraduates to pre-professional students and doctoral students in public health, nursing, and medicine. We also have community members who want to come and learn more about health equity so that they can improve the delivery and the evaluation of their work. Now, let's talk about our engagement with policymakers. All the way back in 2011, we were involved in the Maryland Health Quality and Cost Council's work group and served as advisors to the Maryland Health Improvement and Disparities Reduction Act of 2012. As you know, that authorized the health enterprise zones in underserved communities. And so we're pleased to say that we were part of the advice that led to that legislation and has led to some remarkable improvements in delivery of care, reductions in hospital utilization in underserved communities, and lots of opportunities to improve and reduce disparities in underserved communities in Maryland. We've also continued our work and on a policy level, we've engaged with the Bloomberg American Health Initiative and IBM Watson to develop a method to measure the impact of hospitals on community health with a focus on equity. And so after developing this measure with a lot of public comment and input, it was finally incorporated into IBM Watson's measurement strategy. And now hospitals are using these measures, which include population level health outcomes for the counties in which they serve, their role as a healthcare provider, which includes things like whether they offer services like tobacco cessation, violence intervention, or addiction treatment on site, whether or not they serve as a community partner, and this looks at whether they meet best practices for contributing to community health initiatives, such as incorporating community health workers or home visiting or healthy housing programs. And then finally, another measure is to what extent does the hospital act as an anchor institution? And that looks to see whether hospitals are actually including best practices to diversify their boards and their management, whether they're paying a living wage to their employees, and offering childcare to their employees. As you can see, we've had several large seminars, one of them called The Fierce Urgency of Now, focused on disparities in maternal mortality. We've provided congressional testimonies, and most recently, one of our faculty members, Dr. Chidima Ibe, contributed to a report funded by the ABLE Foundation to examine how to advance and sustain the community health worker workforce in Baltimore City, and it offered some key recommendations for policymakers. During the COVID pandemic, we were highly engaged with a wide variety of policymakers and stakeholders. We participated in panel discussions. We offered briefings to state and local policymakers on best practices for preventing COVID, containing the spread of it, for enhancing vaccine education and uptake, and for improving access to care. So this is just a smattering of some of the op-eds that we wrote and the panels that we engaged in and the briefings we engaged in during that time. So even though, COVID-19 has been a very difficult time for all of us, the silver lining in this cloud is that we've been able to strengthen our conversations and actually bring the best possible evidence to inform practice and policy. So now I'm going to turn over to Dr. Cruz, who will tell us about recent and new research studies.
Sure. Thank you, Dr. Cooper, and thank you, Delegate Pena-Melnick, for being with us today and inviting us for this conversation. I'm very excited to be here. As Dr. Cooper alluded to, one of the key focuses of our Center for Health Equity has been around cardiovascular disease, and in particular, a number of our studies have focused on addressing disparities in hypertension. And so I wanted to highlight here what we see when we think about the burden of hypertension here in the state of Maryland, where the overall prevalence of hypertension is 34%. But what we see among a number of racial or ethnic minoritized groups here on the left-hand side, highlighting they're in green, and those Black individuals here in the state, or those who identified as being of other race, have a higher burden, as well as American Indian or Alaska Native individuals have higher rates of hypertension, including around 41% for Black Marylanders. And then we see similar disparities when we look at income level here in the state. We see similar disparities where those individuals who are earning less than $25,000 per year have the highest burden of hypertension here in the state, or with around 45% of them having a diagnosis of hypertension. Okay, so a condition that for people who are experiencing hypertension, one of the many sort of potential sequelae of that includes kidney disease. And at our center, we recently completed a study to try to address disparities in kidney disease, and really to target a key factor in both kidney disease as well as hypertension and diabetes and a number of other chronic health conditions. And that is the role that access to healthy foods and healthy kind of dietary patterns play in these health conditions. And so in this study, 5+ nuts and beans for kidneys, we built upon the successful original 5+ nuts and beans study conducted at the center to then conduct a 12-month community-based dietary intervention, including 150 Black adults living in Baltimore who had both hypertension plus early evidence of kidney disease. And what we did here through a partnership with a local grocer was to test whether the delivery of nutritional advice to adopt a healthy dietary pattern, that the dietary approaches to stop hypertension dietary pattern, plus $30 per week worth of fruits, vegetables, nuts, and beans that were supplied by this grocer partner. We were testing whether it would ultimately lead to a reduction in loss of protein in the urine, which is an early marker of kidney disease, as well as we were testing whether this would lead to a reduction or improvement in blood pressure for these individuals. We had partners across the state of Maryland, and in particular, a number of them based in Baltimore. Dr. Cooper highlighted some of them in her previous slide, and the results from this study will be forthcoming this year. In a related study, again, really focusing in on the role that healthy food access plays in some of the health disparities that we see here in the state of Maryland as well as across the country, we conducted a study that used a type of research discipline where participants are actually trained to use cameras and photograph something in their environment. In our case, we trained participants to use cameras and take photos of their food environment. And in this project that was led by Dr. Anika Hines, what we did was to invite Black American residents here in Baltimore who had hypertension, again, sort of focusing on this population. And after taking photographs of their individual food environments, we then invited them to have these sort of focus group sessions where they discuss what they were observing through these photos. And this poster of the findings from this project highlighted some of the discussions that were had, or some of the findings from the study, including that many of the participants viewed, in some cases, the lack of healthy food access in their nearby communities as really being an issue of social injustice. And many of them looked to policies and the role that they were playing in shaping their availability and accessibility of foods in their community, and really pointed to a number of different opportunities for advocacy and change. And so we are kind of excited to build upon what was found in this particular study. We recently held, just about a month ago, a symposium that was titled Seated at the Table, that provided an opportunity to exhibit some of the photos from the Photo Voice project, as well as to engage numerous stakeholders who play a role in shaping the food environment, and also who are, I would say, sort of consumers or end users of that food environment, including some of the participants from the Photo Voice project, with the hope of kind of beginning to have a conversation about how we might be able to work together to enhance the healthful food options in Baltimore City. And so about a year ago now, we were very excited to receive funding from the National Institutes of Health for a new center grant, a new large grant called the Mid-Atlantic Center for Cardiometabolic Health Equity, or MATCH. And with this focus on cardiometabolic diseases, our reasoning behind that was that when we think about these sort of set of diseases, these include hypertension, obesity, diabetes, heart failure, and chronic kidney disease. And these are exceedingly common and also collectively considered the leading cause of death worldwide. These conditions also affect several generations within families, and they can develop and actually be made worse at different points across a person's life. And so they really have a kind of a impact throughout the life course. And in the US, as well as in Maryland specifically, disparities in cardiometabolic diseases are quite profound, and they affect both urban, suburban, and rural communities. And so the MATCH Center Award includes in it 3 different research projects, and I'll just briefly summarize those for you. The first is the Linked Hearts program, which is a study or a program that will test the effectiveness of linking blood pressure self-monitoring. Thank you. Linking blood pressure self-monitoring via telemonitoring, as well as team-based care with pharmacists and community health workers, and programs for doctors compared to enhanced usual care, with an effort of with a focus on trying to improve blood pressure control among socially disadvantaged adults who either have uncontrolled hypertension plus either diabetes or chronic kidney disease. And you can see that really for all of these projects, they have a broad focus across the state, and you can see highlighted here the counties that are included in the Linked Hearts program. And this study is led by Doctors Yvonne Commodore-Mensah and Cheryl Dennison Himmelfarb. So in our next study, it's called Healthy for Two Home Visiting Program. And this study will compare the effectiveness of a known pregnancy and postpartum health coaching program delivered as a home visiting intervention it's going to compare that to usual home visiting services for reducing postpartum weight retention among Black and Latino women who are at high risk for cardiometabolic disparities. Many of you may know that there are immense disparities when it comes to maternal health observed for these groups. You can see the counties and Baltimore City as well that are included in this program, and it is led by Drs. Bauer and Bennett. And then finally, the Unload Heart Failure Program. And in this study, what we'll do is to determine the effectiveness of problem-solving training, community health worker support, and partnership with community facilities, including recreational facilities, for enhancing cardiorespiratory fitness. So this is the ability of the heart and the lungs to actually supply enough oxygen to the muscles during physical activity. And we're going to conduct this study among adults with low income, as well as diabetes, obesity, and heart disease, including for people who may not even know they have heart disease. They may have early markers of it and have not yet actually been diagnosed with the condition. And you can see where the counties where this project will be conducted, and it's led by Dr. Cooper as well as Dr. Ciotti and Dumoulin. So this sort of concludes our summary, and we look forward to the discussion.
Thank you so much, Bo, for your work. It's very impressive. And myself, living in Maryland and being a public policy maker, I rely on your expertise. And I'm so glad that I live here and that you exist. You know, during COVID, at the height of COVID, we learned clearly, the data was so clear, that Black and Brown had the highest number of COVID-19 cases. And when we discuss and we thought, why is this? It's because of those social determinants of health, right? It is the way we live, the environment, the food we eat, the lack of transportation, lack of money, lack of education. Okay, so if we have all those barriers, how can we have health equity? It's impossible. So your work is really important, so I thank you. So with that in mind, Dr. Cooper, what has been the program's impact in Maryland?
Yeah, I mean, I'm just so happy to say that we have had impact beyond what we could have even expected when we started out. So I described 3 studies to you that we did when in the first 5 years between 2010 and 2015. And that project that I described called Project Redship, actually we worked with thousands of patients across community practices at Johns Hopkins. And these were all people that had hypertension. And what we found is that by introducing a pharmacist and dietitian team to the primary care team, and by providing blood pressure measurement training to the healthcare staff, that we were able to show a reduction in disparities in hypertension, uncontrolled hypertension. We also found that that program was cost effective, especially for older individuals with hypertension. So we were able to show that that care model was very effective. The only issue with that was that there were some people who were not reached by the program. And that's why we went on to study a program that included community health workers to provide outreach. In our initial 5+ Nuts and Beans trial, it was an 8-week program. And it was focused on people with hypertension, but not necessarily those that were very high risk. So we didn't show an improvement in blood pressure in that study, but we did show improvement in consumption of healthy fruits and vegetables and some biological markers that we knew would be important to protect people from getting damage to their kidneys. So we wanted to pursue that further. And that's why we went on to Dr. Cruz went on to lead the 5+ Nuts and Beans for Kidneys trial, again, focusing on people with kidney disease who might actually really benefit significantly from this dietary approach. So those 2 studies were very successful. The ACT study, in addition, that tested 3 different community health worker programs, all showed improvements in blood pressure control. In addition to our training programs, as I said, we've taught over 200 students in the School of Public Health. We've provided mentoring to over 170 individuals, many who are from underserved, underrepresented groups in medicine and science and public health. We've had our monthly series, which has engaged so many people across the state from different health systems, as well as community-based organizations, as well as academic institutions. So over 7,000 people have participated in those sessions, which are now virtual and open to the public. And then we have our massive open online course. But I would say, like, our greatest impact has probably been in our community engagement. Our community partnership has been very robust. As a result, I think we've engaged so many more people from Maryland into work that addresses health equity. We've been able to offer support to them in their efforts. We've been able to work together to advocate for changes, which really makes our impact even greater. And one of the things we learned from our partners recently is that they actually rate us very highly on a scale from 1 to 5. They rated us a 4 or better on things like addressing the concerns of the community, issues that are locally relevant, disseminating findings and knowledge to everyone, basically making sure that people are equitably involved in decision making, balancing everyone's input, and then planning for long-term commitment and success. And then I mentioned to you all of the different policy efforts we've been involved in. So I'm happy to elaborate upon those further, but I feel like, we're just so grateful that we've been able to extend our impact through our engagement.
I can see your passion, which is wonderful to do what you love and to do it so well. Dr. Cruz, what is the program's future goals? What are the plans for Maryland health equity?
Yeah, so, I think we're very excited about the opportunity through this new award match, the Mid-Atlantic Center for Cardiometabolic Health Equity. I think for several reasons. One, when we think about Maryland, as we are certainly in this conversation, this is really one of our first opportunities at the center to really have projects that are spanning across the state and are really touching multiple jurisdictions, multiple counties across the state. And in addition to the 3 research projects that we are expecting to begin recruitment for, each of those are all clinical trials, and we're expecting to begin recruitment for them sometime next year. But in addition to those, we also will be in many ways able to expand some of our support for early career individuals who are looking to get into and contribute to health equity research through our Investigator Development Corps, which is a part of this award. And so here we have a pilot award program where we're actually providing grant funding to individuals who are either in the state of Maryland or in DC. To fund their research, their in many cases early career research, to sort of help them launch their careers in health equity work. And then we also have a community engagement corps as a part of this new award that will in many ways help us to enhance the work that we've been doing through the Community Advisory Board that Dr. Cooper discussed, and has provided us a new and even expanded opportunity to partner with members of our Community Advisory Board on these specific research projects and making sure that they are responsive to the needs of the communities that we're seeking to serve, and that we will ultimately be able to sustain the efforts that we may, or sustain the work that we really do through these projects and sustain their impact. And so those are some of the things with that new award that we're excited about. We're also really excited about the work we've been doing around access to healthy foods and our efforts around trying to influence food policy I alluded to the Photo Voice Project. We also have a partnership with an urban farmer at Plantation Park Heights Urban Farm, Farmer Chippy. I won't give his full name. He goes by Farmer Chippy. And anyone who knows him only knows him as that. But we are doing some work with him where he, through an award here in the state, was actually able to, or has been able to, provide food boxes to individuals who here in the pandemic have had trouble accessing healthy foods. And we're actually conducting a program now, or a project now, where we're assessing the health impact of that effort through that urban farm. And so we're excited to continue to partner with him. And so we see a lot of work yet to be done, and are really excited about it.
So, Dr. Cooper, what state policies or resources have made the program more successful? And this is an important question for me, working for the state.
Yeah, I think several of the state policies and programs have helped to make our work successful. I think number one, I mentioned to you that health enterprise zone legislation, I think, was highly influential in terms of, providing opportunities for community-based organizations and health systems to partner together, to obtain funding, to develop specific programs that address inequities in health outcomes within the communities they serve. So, we've benefited from that. There's also been several bills that you all passed this year. One of them focused on implicit bias training for health professionals. That's been very important to us, to our work, because a lot of our research has documented that, some of the disparities that we see in delivery of care and health outcomes can be attributed to, unfortunately, to implicit biases among health professionals. So people who are well-meaning, but because of the society that we live in, and because we're human beings, have some implicit biases that affect their care of patients. So we're very glad that legislation has been proposed. Also, establishing the Maryland Commission on Health Equity, that really will provide advice to everyone working in this space on issues related to health disparities, including collection of data, coordination of expertise in developing the health equity plan for the state that addresses social determinants. The legislation on examination of race and ethnicity data collection, and making sure we have standards and that we're collecting this data and reporting it consistently and looking at it to see where we need to make improvements. I think all of those things have been very influential. And then also, I think, last but certainly not least, is that that you all have established a work group focused on looking at community health worker qualifications and opportunities for community health workers to receive training and recognition and certification, and to prepare different organizations to be able to develop and use community health worker programs. So all of those have been extremely positive for our work.
Which I think it's really so important. I know we also passed a bill where we are going to be given grants for the sort of similar to the work that you did before to the community and the goal is to reduce the health disparities as well. So we're constantly looking for ways as policymakers to improve the health outcome in Maryland. So thank you for your leadership. Dr. Cruz, what state policies, resources are needed to further enhance the program's positive impact in Maryland?
Yeah, I'll mention a few, and certainly I'll also invite Dr. Cooper to add to that. So I think there when we think about the work that we are doing, and how a lot of what we focus on is really trying to support people who may be experiencing a lot of financial resource strain and making important trade-offs when it comes to costs that may be more directly related to their health and their health care. They're sort of deciding that they have to use the funds that they have available for other things and perhaps not being able to purchase their medication or do conduct other sort of health promoting activities. And so legislation that offloads that strain, it becomes really important for the type of work that we do. And so things that have emerged in the setting of the pandemic that we would be excited to see continue, at least in some shape or form, including the moratoriums on evictions that emerged, that certainly played a really supportive role for people. The legislation around allowing the use of the EBT cards for the Supplemental Nutrition Assistance Program cards for online food delivery. So that was one that was kind of directly helpful for people who may have even been participants in some cases in the studies that we were conducted to actually be able to safely acquire food, similar to how many others who had those resources were able to, as well as a lot of the efforts and new policies around telehealth. And as we're seeing broadly in medicine, we're seeing an increase in digital health kind of interventions and programs. And we, through the Linked Hearts study that I mentioned earlier, are certainly going to be testing an approach to sort of using this digital health platform to hopefully help to improve blood pressure control. So policies surrounding either whether it's remote patient monitoring, so that I know that was covered by Medicare now a few years ago, and certainly applied here in the state, but also other programs, including the broadband expansion effort that was I believe announced last year. That's going to be important to the work that we do as well.
That's wonderful.
Dr. Cooper, I think, wanted to touch on a few as well.
Did you, Dr. Cooper? Go ahead.
Sure. So as I mentioned before, the legislation around implicit bias training has been very important. I do think that there are some areas that could be improved, in the future. So, for example, we know that while implicit bias is definitely a problem in healthcare delivery, that the evidence for what really works to address it is nascent. And so we think it's really important that with this legislation that, that there also should be put in place some sort of expert advisory board that can actually look very carefully at what these programs entail, look at ways to evaluate their effectiveness and make sure that they are addressing the specific health problems where we really see a significant impact of bias, for example, maternal mortality, that establish qualifications for the trainers and that address funding and access to that training. So we think that there's still room for growth there. We also think that for the community health worker piece, we really applaud the work that is being done so far, but we think it needs to go one step further, really, that we really need to garner some funding for these programs, long-term financing, for example, through Medicaid, also Medicaid reimbursement that includes some sort of clear established training or certification process that involves a lot of stakeholders in the conversation, including community health workers, and that this legislation should also take into account things that we know that are sort of getting in the way of these community health worker programs being successful, things like the need for adequate supervision and the need for stronger compensation for community health workers as a way of them, developing a career trajectory. So we think that there are some areas for improvement there, but we really applaud. Maryland is really, very progressive in terms of a state that is addressing health equity. We talked about the telemedicine policies. There's also policies that legislation that you've introduced are related to reduction of prescription drug costs. And that has had a huge impact on the populations we study and that we provide care for. For example, making sure that the cost of insulin, doesn't exceed $30 per month for people who require insulin for control of their diabetes. So those are the few things that I wanted to add in and just say that it's just just a joy to meet you, and we're just thrilled for the opportunity to continue our conversation and to work together with our communities to address these issues.
Well, I thank you both for your partnership and I welcome it. So we'll talk and make sure, as you know, we're in session January to April, that some of these policies get addressed in the funding. As the primary sponsor of the telehealth bill, the implicit bias bill, the Health Equity Commission, the Drug Affordability Board, the telehealth, all of that. I am very committed and very passionate about these issues. We're very blessed that we have the Speaker of the House where I serve, who is, very committed to health equity, and the Black Caucus and Latino Caucus as well. I think you'll find many partners. So I am excited about our continuing work, working with you. We do have a couple questions actually from the audience. And one of them is, if someone wants to support the work of the center, how can they get involved? Who would like to take that question?
Well, I'll start. I think that one thing you can do is to visit our website, which is healthequityhub.org. You'll see multiple it's .org or .com, either one will take you there, but healthequityhub.com. You'll see a lot about our programs there. There's a page that asks how you can be involved as a community member, or if you're interested in training opportunities. So you can definitely visit that. You can reach either myself or Dr. Cruz. We're easy to find, actually. I'm using Google. We'd love to have your contributions, whether it be financial or otherwise. So yes, reach out to us. You can join us at our monthly Health Equity Jam sessions as well. So you can even click on a link there to find out more about that. And you could email, I guess it's healthequity@jhmi.edu if you want to be added to the listserv for the Health Equity Jam sessions.
Thank you. Dr. Cruz, would you like to add anything to that?
Oh, nothing to add. I don't know if it's visible to everyone, but I dropped those links in the chat, and maybe our organizers can share that with a broader audience.
Thank you. And there's a question that says, really fascinating work for the delegate. How does research like this affect your decisions? How does it enter the conversation around policy? And are there ways we can make the process better? Well, how does the research affect my decision? I rely on the data. I rely on your research because you're the expert. When I introduce a bill, I bring everyone to the table, whether you're for it or against it. And I bring your expertise to the table to be able to convince, my colleagues why we need to fund it, why it needs to pass, right? And why it's so important. So the data really influence the way we vote and the policies we pass. How does it enter the conversation around policy and other ways that we can make the process better? I bring you early on. I think that I rely heavily on what you have to say. And yes, there's always room to make the process better. I think that when we policymakers introduce a bill, we're in session January to April, January until April for 90 straight days. We should start our work early, not in January, during the summer and fall, having meetings. I love the fact that your center works with a community, that you engage other people. It's important to have different perspective and experiences and make those part of the policy and the conversation. So though you are really important in my work, and I rely on it heavily. There is a question that says, and this is a very good one, I know you're gonna love it. Are there projects you want to do, but haven't gotten the opportunity yet? Who would like to take it?
So yes, and maybe I'll start. So I think, a lot of what we've done, it's been at the scale that we could support through the funding that we had available. And so many of the ideas that I have are more about scaling some of the work that we've done previously. And we talked about the 5+ nuts and beans for kidneys study. I'm a full disclosure, I'm a kidney physician, I'm a nephrologist, and so I care deeply about kidney health equity in specific, and would love to see us actually test out a way of actually scaling the type of food provision and coaching around following a healthy dietary pattern for broader populations, not just for people with kidney disease, but also those who have other diet sensitive health conditions like diabetes and hypertension as well. And so many ideas around how that could potentially be scaled in health systems. And so that would be one of my, haven't gotten around to it yet, but hope to in the future ideas. Dr. Cooper has many.
I know, that's why I went straight to her.
So, well, I agree with Dr. Cruz that we could really use funding for ways to scale our programs. For example, we do know that that a lot of the training programs that we've developed for frontline staff around hypertension management and for community health worker trainings and care manager trainings, that there's demand for this, but we can only do it on a small scale with the funding we have. If we had funding, we might be able to develop something that was larger that could be then deployed across many, many more communities and health systems. So I think that's really important. But I also think another area in which we would like to expand our footprint is the idea of a family intervention. So programs that don't only address like the individual within a family, but that will address like the issues related to health disparities on multiple levels. So that because we know that people, they don't live by themselves. They are part of their social network of whether it's their family or their friends or whatever. And we know that when you can influence like a whole network of people, that can change health behaviors and outcomes in a real powerful way. So I think programs that get at the social network of individuals and that really target people, and I shouldn't use the word target, but that really focus on people who are different members of that network to all deal with the unique issues that they're struggling with. The older grandparent is not having the same challenges that a young person who is trying to just get out of school and start their job is having, or that children who are, going to school and dealing with whatever it may be, food insecurity or something else about the way that they are interacting with their teachers. They're all different issues, but they're interconnected. And so how can we do a better job at addressing a problem a little bit more comprehensively by taking into account the whole network of people?
Really important. I know that this past session, when you talk about family intervention or intervention in the community, Delegate Stephanie Smith from Baltimore City introduced a bill that basically would require funding for Medicaid to fund the community violence prevention services, which is so important. So as legislators, we're always looking for creative ways to address these issues and to reduce the health disparities, right? And to have access to care, which is so important, so we can all live a full life, right? And healthy life. So I thank you both for your work because it's really making a difference. So before I go into my final remarks, are there any last words that you would want to say? Dr. Cruz.
Well, just two things. One, thank you for disengaging with us, and thank you for the work that you do. And I'm definitely very excited about working more with you in the future. And I would say that just in general, I'm generally just really excited and optimistic about the fact that so much attention has been drawn to health inequities in the setting of the pandemic, and also recent high-profile acts of racism that has actually led us to having more and more conversations like this, and it fills me with a lot of optimism about what we'll be able to do together in the future. And so I'm just hopeful. And so thank you.
Me too. Thank you, Dr. Cooper.
I also want to thank you for your leadership and the leadership of you and your colleagues, in this space. We are definitely, indebted to you for your commitment there. I guess the only other point I would want to make is that everyone who's out there watching this, that you have a role to play, that, this problem is not going to be solved by one person or one group of people. I just wrote a book called Why Are Health Disparities Everyone's Problem? And in there, I talk about the fact that no matter who you are, whether you're a teacher or a pastor or you're a legislator or, whatever it is that is your passion or your role, even if you're a mother, a caregiver, we each have a role to play. We can take a leadership role within the organizations in which we work or the institutions where we attend church or school. And we can make sure that these issues are brought to the attention of people who are in decision-making roles. We each have a talent or a skill, and that because it affects all of us, when one part of our society isn't doing well, none of us are doing well. And we saw that only too well during the COVID-19 pandemic. So let's all see what role we can play, as individuals and as members of our organizations and institutions, how we can make sure that people who are in leadership roles are aware of and hold them accountable to addressing these problems. And then also that we can step up to the plate ourselves, especially if we come from these communities ourselves, because we actually have the lived experiences. So we can seek the expertise that we need, and we can use our voices to bring about change, just like Delegate Jocelyn has. So.
Thank you so much. I appreciate both of you and the work you're doing. You're leaving an amazing legacy. I want to thank you, Dr. Cooper and Dr. Cruz, for your time and all your work leading health equity research to inform clinical practice and people like myself regarding public policy. As a representative of the Maryland General Assembly and a Marylander, I am proud to have a center like this in our state and be able to partner with you on improving the health of all Marylanders, because you're so important. Your research is really key. It is life-saving, and I appreciate it. I also appreciate learning about this unique part of Johns Hopkins enterprise. And I'm thankful for the investment the institution is making to allow Maryland to lead in this field. Johns Hopkins is highly regarded and respected in the General Assembly. So I always look for your voice. I also like to thank those who tune in to listen. You could have been doing something else, anything else today, and you chose to be with us to have this conversation in the Showcase series. And I am grateful for that, because together we can make a difference. Johns Hopkins Government and Community Affairs team will host more of these events in the future. So tell your friends, go to the website. They will highlight the Anchors Institution relationship to Maryland. So for questions, please email gc8@ghu.edu, gc8@ghu, it's gca@jhu.edu. So make sure you stay in touch, make sure you stay involved, all the local groups, the church, everyone, we can all make a difference. And if you have resources, please donate to them. They're doing great work. It is a pleasure to be here with you today. I hope you have a blessed day. Thank you so much for your time and all your efforts.
Thank you.